So I just really want to turn over to Hart now, and once again thank her for bringing her expertise to this deeper dive into the MIPS improvement activities for us today. So this is just a screenshot of the website, the QPP website, where you can find the improvement activities. We quickly stuck these in here in case you're not familiar to that yet. And I think the next slide also, Emily, is another shot of this website too, where you can go and it's really fun actually to go and search the improvement activities, take a look at them, which ones might work for you, etc. It's a really fun little interactive site. Okay, I'll pass this off to you.
Thank you, Lisa, for including me, and for Henry for inviting us. I'm glad to share with you what I know about MIPS and particularly about improvement activities. This is all new. Everyone's learning it. The rule that outlines these topics is over 2,000 pages long, so it's hard to know everything, but we know some high-level stuff, and we'll be able to dive into it a little bit deeper as we go forward. This is just a graphic representation of the quality payment program, and you can see that it's inclusive both of MIPS, the merit-based incentive payment system, and advanced alternative payment models. And we're not going to spend too much time on the advanced alternative payment models, but we will talk more about MIPS. So I'm going to look at a little bit of an overview of MIPS, of what's changed in quality reporting, what the performance categories are, the concept of a final score. We'll dig into the improvement activities and a little bit about scoring so you can see how that comes together. So what CMS has done is divided MIPS into 4 categories. You can see for each category that there's a percentage associated with them, and that's the contribution that they make to your final score. And your final score is what will ultimately determine whether you receive a penalty or an incentive as you submit data. In the first year, 2017, resource year use counts for 0%. So and that's essentially cost. Any cost measures are calculated by CMS. They're not something that you will ever submit data for. But they won't be doing that in the first year. The first year, it's important to learn what your costs are and to understand what things you'll be judged on going forward. Quality is 60% of your final score. We're not going to talk in more detail about quality. Advancing care information is 25%, and improvement activities are 15%. So what we're going to focus on today are those 15% of the contribution to your final score. So what's changed? Some of you may or may not be familiar with PQRS, but so everything I'm showing you is essentially in the context of PQRS. The new MIPS performance category of quality replaces PQRS and the CMS calculated measures under the value modifier. And if anybody's familiar with the value modifier, that judged your PQRS submission on cost and quality, combined with some CMS calculated measures. So that all gets replaced with quality. Resource use replaces the CMS calculated measures under value modifier that were related to cost. Advancing care information replaces meaningful use for eligible professionals. And I'll mention here very specifically that if you are participating in Medicaid meaningful use or meaningful use for hospitals, those 2 programs continue. ACI will not replace those, and you will actually kind of be reporting the same data for both. Improvement activities is brand new for CMS. So that's why we know least about it in some cases, but they've also given it the least emphasis, and there are, as Lisa mentioned, some very easy wins with improvement activities, particularly for this audience. So this looks a little complicated. It is basically the overall scoring model. I don't want anybody to panic. This is not the scoring model that's going to be used for 2017. But because you can see on the left-hand side, there's no values assigned to that y-axis. It's a model to show you that every year CMS is going to set what they call a performance threshold. And in this example, they're showing that performance threshold as 60. To the right, if you get a final score greater than 60, you begin to be eligible for an incentive. And to the left, if you have less than 60, you begin to be assigned an adjustment factor on the negative side, otherwise known as a penalty. And you'll notice that the dotted line is an area that if you score above 70, you become eligible for what's called the exceptional performance bonus, which is a $500 million pot of money that will be distributed to those that score exceptionally well. The program as it's designed is what they call budget neutral. So the slope of this line and the shape of this line will vary every year depending on how many people fall below that performance threshold. So all the money that is fined or penalized on the left-hand side of that performance threshold will be redistributed to those who score on the other side of the performance threshold. So there's no set adjustment factor. It truly is going to be adjusted year by year, but there is a schedule of estimated factors that go up to 9% on either side. So even if 2017 is easy to start out with, it's going to get harder, and the penalties and what's at stake will get higher and higher. So it's great to jump in 2017 while it's easy, get in the habit and learn about this program so that as things get tougher, as the years go on, you'll be fully prepared and you'll be on the right-hand side of that performance threshold and into the incentive factor. And I'm going to show you how today, just by doing the improvement activities, you can still be on the right-hand side of that performance threshold. So we're going to talk about improvement activities here. So a lot of people ask, well, how do I report a improvement activity? It's actually extremely easy. It's a simple attestation from a list of 90 activities. And Lisa alluded to the CMS website where you can find out what those 90 activities are. The specifications that they give you on that website are the only specifications you will receive. They're not being more specific or more directive of what constitutes compliance with any one activity. They're really leaving it very much up to your judgment about whether or not the activity applies to you. So if you think that it does, you will attest either through a third-party vendor. Mingle Analytics is one. They may have some free CMS portals available for you to report. They have told us they're going to, but we haven't seen any evidence of it, so I wouldn't count on it, but it's very possible that they will. And all you'll have to do is check off a activity and essentially you're attesting to say, yes, we are doing this and have been doing it for 90 days. And there are no practice or provider participation thresholds, so you don't have to say, well, how many are doing this or not doing this. If you're reporting individually, one provider, the provider has to participate in the activity. If you're reporting as a group, just one provider will cover the entire group. So they've really set a very low bar for your participation in these activities. There are a couple of activities, maybe only one actually, that does require you to have been doing it, I think, for 6 months. So watch out if that's one of the activities. That's the only caveat to the 90 days, is that occasionally an activity will require participation for 6 months. There is no audit on the part of registries that are going to be collecting this data. So Mingle Analytics as a registry will take your attestation. You won't need to prove to us that you've done this activity. However, anything that you submit to CMS, they may conduct an audit. So you have to be prepared to substantiate what you have done for that improvement activity. And very often, some of them involve meetings or extended hours, things like that. Think about the normal things that would give proof that you've participated in an activity: minutes of meetings, screenshots from your schedule, notes that you keep somewhere. There's not a high requirement on what constitutes documentation of these activities. So the scoring works like this for activities. Remember that the category itself counts for 15 points towards the final score. Those points are divvied up among 40 possible points after you've chosen your activities, and then those get weighted in the final score. So they've divvied up the improvement activities according to high-weighted activities, which are worth 20 points, medium-weighted activities, which are worth 10 points, and low-weighted activities, which are reserved for later years. And you can do any combination of 10 and 20 to get up to the 40, but there's also some special scoring, and we'll talk about that on the next slide. So there's special scoring for a practice with fewer than 15 providers, and my guess is that that's true of many of the practices that you're working with as PTNs. If they are rural practices or health professional shortage area practices. And I understand from working with the Northern New England PTN that that is something that had to be determined when you enrolled in the PTN. So if you don't know if you're a rural practice or a HIPSA practice, that the PTN has that data for you. There's specific tables that you have to check and confirm that you are a rural designated practice or a health professional shortage area practice. And they're determined by zip code. There are also special scoring for non-patient facing MIPS eligible clinicians. So for example, pathologists typically would be non-patient facing eligible clinicians. They get double points. So any of those categories get double points. And there are specific activities that if you choose these improvement activities, they will count towards bonus points in the advancing care information category. So all the three categories are very interrelated, and you want to be aware as you do that to see, because each one will influence your final score. Let me just check. I'm going to check for chat to see if there's a couple of questions. Okay. There's one question about hospital. Let me just a sec. Hospital will continue doing meaningful use, but can you clarify which hospital-based providers we will need to complete MIPS for? I don't have my slide with me today that talks about all the different categories of eligibility for MIPS overall. That's information I can get to you. It's basically physicians, anybody with MD, optometry, psychiatry is MD, DOs, anyone that's considered a physician is eligible, as well as nurse practitioners, physician's assistants, CRNAs, and clinical nurse specialists. So a lot of the occupational therapists are not included this year. Urgent care, if it's an MD, NP, or PA, would still be included. Okay. So to determine whether someone is non-patient facing or not, you will, it's based on whether they bill 100 or fewer patient-facing encounters, and there's a specific list that CMS has to determine those patient-facing encounters. And it does, patient-facing is considered telehealth, or telehealth is considered patient-facing. So if you do any telehealth services, those count as patients-facing. If you're reporting as a group, it's 75% of the NPIs billing under that TA and must meet the definition of non-patient facing to be considered in that category. There's a determination period that CMS will use to decide if someone is non-patient facing or not. So the determination period Medicare will determine if someone is exempt from MIPS. So back to the question about who has to report. They will use that determination period for a lot of things, including whether someone's totally exempt for the rules from MIPS, whether they're non-patient facing, or if they are hospital-based, because there are rules for each of those category of providers. They have told us that they will send letters by the end of March, but given that it's March 23rd, we haven't seen them yet. They did say they'd be out by the end of March. They also said that they will be a portal where you could enter an NPI and check to see about eligibility and whether someone fits one of those special categories. The determination period will be based on 2 time frames. They will do a look back to September of 2015 and through August of 2016. And again, they'll do it September 2016 through August of 2017. If someone is excluded or designated non-patient facing or hospital-based during either of those timeframes, the exclusion will always win. So for example, if someone was exempt based on meeting the criteria for non-patient facing in the first time period, but then they wouldn't meet it for the second time period, they will still be excluded based on the first time period. So exclusion or exemption always wins, even if they are not excluded or not exempt during the second determination period. If by any chance a practice is already a designated patient-centered medical home, they get the full 40 points right off the bat, which kind of helps you see that CMS is very much encouraging patient-centered medical home, and that the improvement activities are all focused on things that you would be doing for patient-centered medical home. So if anybody hasn't reached that patient-centered medical home status yet, but are doing several of the activities that would get you to that point, you can probably repurpose each of them and come up with easy win on points towards improvement activities. The list that you see in the pink there are the various bodies that can designate PCMH that CMS will recognize. And if the body that has recognized your particular organization as PCMH is not listed there, it gives the criteria there at the bottom for the other criteria in order to be someone that can designate a PCMH. So then the question comes up, how can you possibly choose among 90 different activities to know which ones apply to you? So I've kind of set up this hierarchy for how to get started. First, determine if your HIPs are rural, fewer than 15 providers, or non-patient facing. You don't have to be all those things, just one of them. That automatically gets you double points. So to start with that premise, because once you have the double points, then you know how many more points you need to get. And if you think about it, it's only 2 more medium-weighted activities or 1 more high-weighted activity. Then you look for things that you're doing already, and there's improvement activity CC-4, which is a high-weighted activity, means it earns 20 points for TCPI participation, which is all of you. All the practices that you're dealing with would be able to claim that particular activity, and it's 20 points. So combined with the fact that you might be HIPs or rural, less than 15 providers or non-patient facing, already just by TCPI participation, you've earned the 40 points. And if you aren't one of those other categories, there's probably another activity that you can choose that will get you there based on the things that you're doing for other things that you're doing for TCPI participation. And I think we're going to talk about a couple of those that coming up. You also might want to review the list of activities that give a bonus in advancing care information, because I think that Emily's going to send out a fact sheet that includes the list of improvement activities that give you that bonus. So why not, even if you could choose the one for TCPI participation, you might want to choose a different one if it's going to give you some bonus points in another category. So think of it as everyone can succeed on these improvement activities. I'm sure there's things you're doing. So here, just kind of an overview of the different combinations that will get you to the 40 points. You can see if you're greater than 15, you can do 2 high-weighted, and down below, if you are less than 15, and that should be less than or equal to, I apologize. You get the double points. You can do just 2 medium-weighted or 1 high-weighted activity also will get you there. If by any chance you are participating in the Medicare Shared Savings Program, those also have kind of automatic points assigned to them, and probably anybody that's in the PTN isn't in an MSSP, but I thought it was important to bring that in, that there's just that awareness that if they're in a Track 1 MSSP, they still need to participate in MIPS and this category. So here's an example for some radiologists, because a lot of people will say, oh, well, you know, we don't do those in practice improvement activities. It's not typical for a radiology practice to operate in the same way that a primary care practice might. And so we have someone here on our clinical informatics team that went through all the activities and said, gee, if they do reminders for mammograms, that counts for improvement activity 13. If they're doing any kind of patient satisfaction survey about looking at the wait times or comfort in the exam room or something of that sort, that would be improvement activity EPA 3. If they're doing if any of the radiologists are participating in the hospital-based quality improvement departments, those would count. If they have some sort of policy for following up with abnormal test results, this is one you would want to document if it's not documented already. In other words, there's a lot of things you do in a practice that you just do, you know, but it's not written down anywhere. So it might be good to document this one to prove that you are, but otherwise you could do sort of a chart audit to show that you've made phone calls or followed up timely on any of these, that you would be proof that you were doing it as well. There might be protocols that you have in place as a radiology group, or a culture of safety assessment that you're doing that works well for hospitals. A lot of hospitals have safety programs. So that's just a kind of an example of how varied the improvement activities are, and there's kind of something for everyone in this. And so now I want to show you that in 2017, they have this notion of what they call pick your pace or submit some data to avoid the penalty. And you can do that 3 ways. You can submit 1 quality measure, 1 patient, 1 visit, so it's as minimal as that to avoid the penalty. You can submit 1 improvement activity for 90 days. You can pass all base score measures in advancing care information. So any one of those things will earn you, will make sure that you avoid the penalty. So if you'll see that, remember we talked about the fact that just by your TCPI participation, that you could earn 40 points if you're a small practice, rural, or HIPSA. So because they doubled, so essentially you would earn all 40 points for the category, which when you scale that for your final score, the 15%, it gives you the full 15 points in that category. So if you look at this chart compared to the other one, this is the one that shows what the slope of the line looks like for 2017. Rather than, what they've done is they've set the performance threshold equal to 3. If you remember on the other chart, it was equal to 60. So this year, for 2017, the performance threshold is just 3 points. So that's all you have to earn in order to avoid the penalty. So you'll see right at that 0% line that just kind of drops off, that if you have anything less than the 3 points, it drops down to the -4%. But if you just do your improvement activities, you are already in the incentive range. You'll notice it's not going to be much. On the left-hand axis, they are estimating that you have to get up to 100 points in order to earn the 1%, or you have to get up to 70 points to get to that exceptional performance bonus to be able to earn over 1%. So you can see, even though it was slated to go as high as 4% in 2017, the reality, now that they've made it easier, is all of that budget neutrality, because they've made it so easy to avoid the penalty, they anticipate there'll be much less money to distribute on the incentive side. So you can see that the incentives are not as great. They're not as high as they originally estimated, which was 4%. But just by doing improvement activities, you're already in that incentive range. So our position here is submit something in every category, and you can move quickly up that line and earn and get very close to that exceptional performance bonus. Many of you will be able to achieve that.
So we just have a couple questions that came in that I just want us to address, and then we'll quickly move forward. Gay, could you just describe, for double scoring, does it matter how many locations for one health center are an NCQA patient-centered medical home to get the maximum points?
It depends how you're reporting. Everything is reported as by tax ID. So if the tax ID is reporting as a group, then just one site can be certified. And you have, let's say you have a tax ID, but you have 5 different sites. If any one of those sites are considered patient-centered medical home, it covers the entire group, whether the other ones are patient-centered medical home or not. If you're reporting as individuals, then it would only apply to the individuals at that particular site.
Okay. And could you clarify a little bit more about what participants actually need to do to meet the TCPI reporting requirements?
I think that would have to be determined between the practice and someone enrolled in a PTN, so that if the PTN acknowledges that that practice is enrolled in good faith and doing, participating at the PTN levels that are expected, then that would be satisfying it.